Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, I'm Nikita Consul, and this talk is about the appendix, where we will journey through what I think are the top reasons to actively search for the appendix on every cross-sectional body imaging scan. The appendix is a blind-ending vermiform structure that arises from the cecum of the large bowel. In cross-section, it contains a serosal layer, smooth muscle, submucosa, and lymphoid aggregates within the lamina propria. That brings us to reason number 1 to not miss the appendix: acute appendicitis. The pathophysiology of appendiceal inflammation is centered in that lamina propria, with lymphoid aggregates that can give rise to lymphoid hyperplasia or even lymphoma. For example, lymphoid hyperplasia due to infection, or inflammation due to dilatation upstream of an obstructing mass or fecalith. CT, by the way, has high accuracy for the diagnosis of acute appendicitis. CT signs of appendicitis include dilation greater than 6 to 10 millimeters, wall thickening greater than 3 millimeters, and periappendiceal inflammation. A 26-year-old patient with suspected appendicitis underwent CT. Multiplanar CT evaluation showed right lower quadrant bowel-like structure arising from the cecum. On axial plane, the classic appearance of a dilated appendix with caliber 1.5 centimeter and thickened walls was found to be compatible with acute uncomplicated appendicitis. Sometimes the appendix that cannot be found is due to an underlying pathology, and this is reason number 2 to always look for the appendix. For example, this 25-year-old man presented with this finding on CT. Arrows showing a right lower quadrant region of inflammatory mesenteric edema and pericecal fat stranding, which on coronal plane surrounds an ill-defined appendix-like structure that was very challenging to find on the previously shown axial plane. And this was determined to be a thickened, acutely inflamed appendix that had perforated. Keep in mind that if you could not find the appendix in the right lower quadrant, this could be due to prior removal or presence in a different location, not always because of perforated appendicitis. This brings us to reasons number 3 and 4. Reason number 3 being that documenting variant locations can help diagnose atypical abdominal pains. For example, in this pregnant patient with a confounding midline abdominal pain presentation, the midline tubular structure was found to be a mildly thickened appendix in a midline location, causing midline appendicitis pain. And reason number 4, in the setting of a removed appendix, sometimes you may diagnose prior appendectomy, but sometimes you may diagnose stump appendicitis, such as in the 64-year-old man with prior appendectomy and new right lower quadrant pain. You can see the surgical clip from the prior appendectomy there at the arrow. On to reason number 5, the appendiceal appendage. This 31-year-old woman presented with right lower quadrant pain and was found to have a small diverticulum at the yellow arrows located at the base of her appendix, highlighted in blue. The trace surrounding fat effacement and stranding was compatible with appendiceal diverticulitis. Speaking of inflamed entities associated with the appendix, this brings us to reason number 6 to not miss the appendix. You may diagnose a whole different itis, such as in this 55-year-old man who presented with right lower quadrant pain out of proportion to a mildly dilated appendix highlighted in blue. Notice the epicenter of inflammation is just posteromedial to the appendix circled in yellow. Additional images in coronal plane show that the inflammation is along the cecum. And at the arrows, we see a tiny diverticulum budding from the cecum encircled in white. And the blue donuts mark cecal wall edema, also reactively inflamed. In summary, this is a case of reactive appendicitis due to an itis of a cecal diverticulum. Moving on, reason number 7 to not miss the appendix is to tabulate at yet another location any possible metastases of a known cancer, especially on staging examinations. For example, in this 38-year-old woman with melanoma, this focal thickening along the appendix was called a possible metastasis. Speaking of metastases, this brings us to reasons number 8 to 10, or in other words, cancer, cancer, and cancer. Primary appendiceal neoplasms are a do-not-miss entity. The pathophysiology is a mucin-producing tumor that circumferentially arises from the mucosal layer along the epithelium and can be benign or malignant. The algorithmic overview of differentiating underlying pathologies of a so-called mucocele into different types of appendiceal neoplasms involves assessment of size and additional features. To begin with, let's look at an example of a mucocele easily picked up on CT. This 59-year-old woman had a 3.1 centimeter caliber mucocele that was promptly removed due to size above 2 centimeter and found to be a low-grade appendiceal mucinous neoplasm. Recall in our algorithm that mucoceles less than 2 centimeter may represent benign retention cysts and may just be followed, while those greater than or equal to 2 centimeter are concerning for neoplastic occlusion. In this case of an 86-year-old man with prior appendectomy for a mucinous adenocarcinoma of the appendix, we see why these greater than 2 centimeter appendiceal neoplasms are removed, as the flagrant mucin production from the peritoneal metastatic deposits can lead to the classic pseudomyxoma peritonei. Looking again at our algorithm, we are reminded that true pseudomyxoma peritonei caused by underlying appendiceal malignancy is different from the benign mucin collections that may be seen in the setting of benign epithelial appendiceal neoplasms. In another case of a now 64-year-old woman patient with a known mucocele, here shown with nodular enhancement along that posterior aspect. Later, the same patient presented after 1 year with peritoneal masses compatible with carcinomatosis, indicative of likely cecal or colonic origin, rather than truly the appendix, as recall in our algorithm that appendiceal cancers are mucin-producing and the carcinomatosis is typically due to underlying carcinoid or colonic adenocarcinoma. The general take-home message here is that most appendiceal mucoceles may require surgical management to prevent metastasis of underlying cancer, and so detection of these is important. Hopefully, I have convinced you with 10 reasons to always look out for the appendix on every abdominal scan. Best of luck, and thank you for tuning into this episode of the Radiology Vault.